So without further ado, I'll introduce our morning plenary speaker, Dr. Peter Rosenbaum. He is a professor of pediatrics at McMaster University. He is among the most experienced developmental pediatric researchers in the world. He is the co-founder of CanChild Center for Childhood Disability Research, an award-winning multidisciplinary health system-linked research center. Dr. Rosenbaum has more than 80 peer-reviewed research grants and is a contributing author to over 280 peer-reviewed journal articles and book chapters. He has recently co-authored a book, Cerebral Palsy, From Diagnosis to Adult Life, and is co-editing a forthcoming book, Life Quality Outcomes of Children and Young Adults with Neurological and Developmental Conditions. So we look forward to a very exciting talk this morning from Dr. Rosenbaum, and I'll welcome him now to the stage.
Thank you very much. Don't sit over there because it's leaking. I'm not sure whether the swimming pool is beside us or above us, but if it's above us, we're in trouble. It's a pleasure to be here. I'd like to thank the Canadian Physiotherapy Association for this opportunity to share with you some ideas that we've been thinking about and talking about for quite a while at CanChild. And as you'll see in the subtitle, asking whether talk is cheap, I think that's for you to decide. So I really hope that people will ask questions and contribute to the discussion as we go along. The background of this is that a year and a half or so ago, I gave a talk in Durham in England and decided that I would put forward some ideas which my colleague Jan Willem Gorter and I put into a paper called The F Words in Childhood Disability. I swear this is how we should think. And I'm going to share those with you this morning along with some questions for you to think about. The F words will be familiar to some of you. Certainly all the words in English are pretty regular words. And some of you may know some of the ideas that I'm going to talk about because you've either heard me talk or you've seen the paper. But the idea, as I said a minute ago, is to stimulate discussion and to have you challenge us, because the more challenge we get, the more opportunity we have to think about whether we're on the wrong track or to make our arguments a little clearer based upon the challenges that people like you put forward. I've been in the business of childhood disability for 40 years, and that gives me the advantage of being able to look back and to see where we've come from, to realize that the original F word was fix. And I think fixing is a fabulous idea. I just don't know that we do it very often, certainly not in my business. And in the course of the last 40 years and reflecting on what we've learned and what we've tried to establish as being useful and finding out what isn't useful and finding out what is useful, it's caused a number of us to think about how we might reframe the arguments about what it is we're doing in working with kids with disabilities and their families. I'm not going to give you a lot of research evidence in the sense of lots of references on the slides, but all the ideas that we're promoting are based upon reasonably substantial research evidence. So let's have a look. If you don't understand this slide, ask the person beside you. The WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. How many people here are completely healthy? It's really quite a sobering idea to realize that we all have things that may make this state of complete physical, mental, and social well-being a challenge, but many of us are coping. And a recent definition of health that's really quite interesting, and I think applies certainly for in the business that we're all in, is health is the ability to adapt and to self-manage. And that's both a philosophical notion and I think quite an important practical reality. So the ICF, how many people here have not heard of the International Classification of Functioning? Some of you, okay. I need a hand or two just so I can say, okay, I have something to show you. Otherwise you're wasting your time. What we like about the ICF is the framework which shows a series of connected ideas, which I'm going to show you in a minute. And I think that this is a really important way of thinking about health for all of us, not just for the people that we work with in our business of manual therapies and disability. And what we like about this set of concepts, and they inform all of our work at CanChild, is the way in which ideas are connected with one another. I personally have a huge problem with the classification, and the ICF, the C in ICF was classification, was meant to be a way of classifying all sorts of impairments and difficulties. And I think it's really quite a crude classification. And as somebody who spent a lot of time developing classification systems, I can tell you there's a lot of work still to be done. But this was taken at my house. Let's have a look at the ICF, and just to remind you that any health condition, and because I'm a developmental pediatrician, I usually put CP at the top, any health condition can be thought about as having manifestations in several dimensions of a person's life, with respect to body structure and function, with respect to activity, with respect to participation or the limitations that a health condition might impose in the context of relevant environmental factors, and contextual factors, which include environment and include personal factors. And I must say that some of this, when people present it and talk about it, you say, yeah, we know that. And there's nothing here that's very magical conceptually, except that there are things we recognize that we haven't necessarily known. So for example, let me obsess about one small point, the environment. When we see kids with disabilities in clinic, we assess them in environments that are set up to allow them to show us their best ability. And then we assume that whatever we're seeing in clinic is what they should be doing all the time, forgetting that other environments, other physical environments, may be quite unforgiving when it comes to slippery floors or crowded hallways and so on. So these ideas collaboratively together, I think, open up some opportunities to think differently. And as a physician, and presumably as physiotherapists, you've been trained to rule out. You've got a problem and rule out this, rule out that, focus down. I like to think of the ICF as a rule in, as an opportunity to say, yes, there's a problem in body structure and function, but there's also an environmental issue, and there's also personal factors here that may be important. And collectively, these things may help to inform us and provide a picture for us that is different from just getting down to the diagnosis. So, as I said, the ICF framework connects a number of elements. I like to steal an idea from my NDT colleagues who talk about dynamic systems. And I think that the ICF framework presents a dynamic system of interconnected ideas. And if you poke one, you may influence others, and I'll come back to that later. I can tell you that this thinking opens up new ways to talk with parents and with kids and with each other. And so what we've done is to populate the ICF framework with a series of F words, and as I have already challenged you, I want you to challenge me as to whether this makes sense. So the first F word is functioning, as what people actually do. And obviously it fits into the activity component of the ICF. And by the way, if you remember the ICF, you might remember the 5 F words. And if you remember the 5 F words, you might take the ICF framework away with you. So you get 2 for the price of 1 in this package. And so the question is this different from before? And some of you are rolling your eyes and say, well, what the hell is he talking about? We've already known this. And the answer is yes, it's different because we've traditionally thought that we had to start by attacking body structure and function. And the International Classification of Impairment, Disability, and Handicap, the World Health Organization's 1980 framework, was a linear framework that started off with a box on the left side which said health condition, and moved to impairments, which was what was broken, which moved to disability, what you can't do, which moved to handicap, which is how you're screwed up in your life because of these problems. And it was a linear progression from left to right with the arrows going one way. So the ICF framework that we've just looked at is really a major step forward, because the arrows have two heads and things go back and forth. So the original notion was we had to intervene at the level of the impairment. And we then assumed that once, in the case of cerebral palsy, once the spasticity was improved, once the reflexes were inhibited and so on, that function would follow. You'd pick up your bed and walk. And my colleague Virginia Wright's PhD thesis showed very clearly that we can influence body structure and function, for example, using botulinum toxin in kids with spasticity, and make major differences in body structure and function. But that does not necessarily translate to changes in activity, let alone changes in participation. So the ain't necessarily so notion is really important, because with the best of intentions, and there may be good reasons to use botulinum toxin and inhibit spasticity, it isn't necessarily automatically going to lead to change in function. Is this different from before? The second yes for me is that we have our default position in child health has been normal function. And if anybody can tell me what normal function is, I'll be very pleased to know, because I don't know. I want to make a very quick sidebar comment and make the observation that we have imported into childhood disability notions that I think are highly relevant in adult medicine. After my stroke, I would like all of you, or as many of you as want to help me get rehabilitated, to get back to the state I was in before my stroke. That's really important to me. It's really important in what we do. But we have a marker of what I could do prior to my stroke, prior to my MVA or whatever. In kids, we don't have that, and so our default position has been normal development. Well, half the kids in the world are going to be below average on anything, and half are going to be above average. So, the whole notion of promoting normal function is really a challenge. And I like to remind people that probably 15% of us are left-handed. Many of us in this room, especially people my age, are wearing glasses. That's fine. If we were all in wheelchairs, that would be kind of odd. If we all had hearing aids, that would be kind of odd. But where's the line here? So I like to think about the ICF as encouraging us to build capacity and not prescribing how things have to be done. And I'll come back to this point in a minute. Important to remember the difference between capacity and performance. Capacity is what we do at our best, and performance is what we usually do. Hands up everybody who performs at their capacity all the time. Gotcha. So performance depends in part on capacity. It improves with practice. It improves when we're interested in doing it. Just think of all of you who've either had piano lessons or encouraged your kids to have piano lessons. If we practiced because we were interested, a personal factor, we probably were better at it than if we didn't practice because we weren't interested in it. And even those who practiced, some of us were better than others because we had natural musical ability. So there's a whole lot that goes into this besides the basic exposure to therapy or piano lessons. If we think about what kids are typically doing, we can recognize easily that kids with disabilities, kids with impairments, may be deprived, not because they have bad parents, not because they live in adverse circumstances, but think about a 2-year-old. 2-year-olds are adolescents in training. They are sort of mini terrorists. Gazelle described 2-year-olds as being motor-minded. And think of all the learning that a 2-year-old does using their motors, their fine motor skills, their gross motor skills, and so on. And then imagine a child who is otherwise as interested as the 2-year-old I just described, but has a motor restriction, or a speech restriction, or a vision restriction, whatever restriction you're interested in. We're talking about motor function today. And then think about the deprivation that's associated with that. And so when we're talking with parents, we need to remind parents of what the kids would be doing if we fix them, and then trying to encourage at least some of that. And that's what child development is about. And by putting all our eggs into the impairment basket and putting lots of effort into therapy to help kids function normally, we may be missing opportunities to allow and encourage them to function in some way or other. Now, I can't resist the opportunity to irritate a room full of physios. This is a unique opportunity by talking about W-sitting. And the pediatric physios in the room will know that this is something you're supposed to discourage kids from doing. And those of you who don't work with kids will remember back to when you were training that W-sitting was something that kids with diplegic cerebral palsy can do quite easily because they have increased internal rotation of their hips. And we want them not to do that because we say it's bad for their hips, it'll cause internal rotation, when in fact the reason they can do it is because they have internal rotation of their hips already. And by the way, it's an extremely adaptive position because when they're sitting that way with their outrigger legs, they're not falling over, their hands are free for play, their backs are straight, and they're very comfortable. Now, this is a true story. I have often said to parents of kids who either are W-sitting or who I know probably can, I say to the mother, does she W-sit? And the mother says, gets a bit chagrined, says, well, yes, she does. I say, well, what do you do? She said, do you try to stop her? Yes. Does it work? No. Now, I say, well, let her W-sit. I've had mothers come over and give me a hug. And that's just practical. I'm not looking for hugs, but it's a practical reality. If that's an adaptive position for that child, let them do it. And by the way, when somebody can show me the prospective longitudinal study that shows that this is bad for their hips down the road, I will change my tune. But until then, I do not believe this damages hips. Anyway, enough of irritating you. So functioning, I think that the ICF encourages us to think about activity. And if we think about how kids do things, first they learn to do them, and then they learn to do them better. And if they're interested, they may develop some skills at it. My 2-year-old granddaughter is here with us at this meeting. I don't think she's here this morning or she'd be yelling at me. And if I walked the way she walks, I would probably be stopped on the street and asked whether I'd wet my pants. But, it's perfectly adaptive for her. And she will walk better and better and better and probably be very athletic like her parents. But, we're so stuck on a certain view of things that we've forgotten that there's a whole developmental element to this and that it's important to remember that kids are doing things differently than adults simply because they are kids in a process of development. And how nicely they do things is really not important to them. And this then, as I say, philosophically moves us toward the notion of achievement and past and hopefully beyond the notion of normal. This is not my granddaughter. So the first takeaway message is stress functioning without regard to how nicely it's done. Prescribe mischief. I've had parents come in and I'll ask how the child's doing, and I remember one mother said to me, he's getting into a lot of mischief. That's good, isn't it? And this is a parent who had older kids and who recognized the value to the child and to her of seeing her child in a different way. And help parents to see their child's strengths. It's a very revealing question to ask a parent of a child with an impairment, what are they good at, or what do you want to brag about? And some of them can't answer that because based upon their encounters with the likes of us, they and we have focused on what the kids can't do. That's really a problem. We need to start off by saying, what are they good at? What do they do for fun? Because when the parent is looking at the child differently, they're seeing the child differently. When they see the child differently, they interact differently with the child, and the whole transactional process is a different one. The second F word, family, an essential environment for all children. And there are all kinds of families. And isn't this obvious? Well, again, yes and no. The traditional patient was the child. When I was training at a big city hospital in a city about 300 miles west of here that shall remain nameless with a very fat mayor, we admitted kids to the hospital, and the parents had visiting hours. they were allowed to visit their children. Now, I presume in most places that's not the case anymore, but what I'm getting at is that was the tradition with which I was brought up. And we brought the kids into hospital and we tried to fix them. And that's what we do with our car, but I'm not sure it works particularly well with kids. And I think we've missed a lot of opportunities to engage with families about their child and their life journey and their career as parents of a child with special needs. Families are obviously central to their children's lives, and we know from a lot of work that we've done, both at the clinical and at the epidemiological level, that parents' lives are complicated when they have extra concerns about a child with a chronic health condition. And the evidence includes impairments in physical health and impairments in mental health. And at an epidemiological level, there is a lot of evidence to show this. This does not mean all parents are going to hell in a handcart. It does mean that their lives are extra stressed by virtue of having a child with a complicated life. And I think it's really important that we be aware of that in the way that we work with them, in the way we respect their views, in the way we encourage them to do things, and give them allowance for not being compliant with our advice, even our good advice, because there's other stuff going on in their lives. And I like to talk, especially now that I'm a grandfather, I like to talk about grandparents, and I've been interested in this for years. The parent that I'm working with in the clinic right now is a fellow adult. They're there in the role of parent, but they are likely also somebody's child. So hands up everybody in this room who is somebody's child. You know, how many of you talk to your parent and the parent says, are you getting enough sleep? How are you doing? Is your cold better? You sound tired. You know, we're a bunch of adults. We're a bunch of professionals, and we have our parents worrying about us. So the role of grandparents is one that's really worth thinking about in the context of this particular F word. And I won't go on with that. But as I say, we've done a lot of work in looking at parent physical and mental health. Families, we've done a lot of work and published quite a bit of literature on family-centered service, which parents tell us refers to engagement with them as partners in their journey, treating them with respect, which means listening to them and valuing what they have to say, the notions of continuity of care in our relationships with them, and so on. And we have good evidence that when family-centered, when services are perceived to be more family-centered.
I'm sorry to interrupt, Dr. Rosenbaum. I'm just going to interrupt you for a couple minutes. I'm a little concerned about the people over here under this leak that we had earlier this morning.
Yeah.
So I'm just going to ask anybody in this area here, tell what we're trying to see over here. Okay, so maybe
Yeah. If you're getting wet, move. Yeah. I've given lots of talks in lots of places. This is a first. The leaky roof talk. There's room at the front, and I promise not to ask you questions. Okay, I'm going to keep talking because I'm losing time, if not my audience. So we have lots of evidence about the relationship between parents' experience of services, the family-centeredness of services, and their satisfaction with services, their mental health, and the amount of stress they experience in dealing with the likes of us. So there's no question. These are robust findings and have been replicated in other languages in many countries. The other thing I want to talk about is goal setting with parents. And our colleague and friend at NetChild, Marilyn Kettelaar, did a beautiful study, which if you haven't looked at is well worth looking at, in Physical Therapy in 2001. And she did a randomized trial in which kids with cerebral palsy aged 2 to 7 were randomized either to have therapy done by a physio who set the goals, or to have therapy services provided by a trained physio who addressed the goals that the parents identified or that the older kids identified. And what she found was that at follow-ups 1, 2, and 3, which were 6, 12, and 18 months after the intervention, there were substantially different outcomes as measured by the Pediatric Evaluation of Disability Inventory in favor of the parent and child goal-directed interventions with less therapy. Really, really important. This wasn't simply a better outcome. It was a better outcome that was more efficient. And sadly, this doesn't seem to have attracted nearly as much attention as it should have. It was a very, very well done study. But it goes against the grain because, one of the kids in this Netherlands study, one of the goals of the parents was that this 6 or 7-year-old needed to be able to get into the barn to help with the chores. And the intervention was providing a step so that the child could get into the barn. This was not stepping up therapy. This was not stair climbing therapy. This was a practical intervention. And this is what the family wanted. And we have anecdotes like that from the study that Mary Law and Joanna Dara did, a very substantial randomized trial, again looking at so-called functional intervention compared with impairment-based intervention, and found equivalent outcomes in both groups. The kids, there was a big concern from NIH, which funded the study, that the kids who got the context and therapy would have more impairments in range of motion. Turns out that, so we had to give all the kids some stretching, which is one of the holy grails of intervention in our field, and there were absolutely no differences between the kids in either group. So this is another myth shattered. So family is really important. So takeaway message: embrace family-centered services, listen to parents, respect them, try to work with them on their terms. The concept works, and parents are, after all, the world's expert on their child. Really important message to remember. The third F word, fitness, something that is often neglected. I don't know where this came from, but I think this is one of my all-time favorite slides. So I'll let you digest that one for a minute. We know that kids with impairments are less fit than they should be, and my colleague Jan Willem Gorter, the co-author of the paper, is trained in adult rehabilitation, is very interested in adolescents and young adults with developmental disabilities, and has a major interest in fitness and well-being of these people, and working with some of our experts in physical medicine and in fitness to look at the downstream effects of being an impaired child who isn't fit. And clearly we know that environment's important. We also know that policies affect children. And Alan Culver, a colleague in Newcastle, has done some very nice work showing variations in various kinds of outcomes across the counties of Northumberland. And this work has been replicated across Europe, and I'll refer to that in a minute. And this has to do with policies for kids, not just policies for kids with disabilities. Olaf Verschuren, who is another Dutch colleague, and we have a very close connection with NetChild, which you'll see at the bottom left of the slide. NetChild is the godchild of CanChild. We've been around for 24 years, and NetChild was started about 10 years ago. And Olaf ran an exercise program, a randomized controlled trial, and showed that indeed you can implement easily and effectively and in an enjoyable way an exercise program that changes the fitness of the kids. But when the program ends, the gains get lost. So we have to figure out, knowing what we should be doing and knowing how to do it, we need to figure out how to make it sustainable. So the third takeaway message is think fitness and think activity. We need to think about policy, clinical and policy issues that are good for all kids. And I mentioned the SCPE, the Surveillance of Cerebral Palsy in Europe studies. This is a very large collaborative effort of about a dozen countries and the cerebral palsy registries in these countries. And they published a paper 3 or 4 years ago that showed substantial variation in participation and engagement of children with cerebral palsy across Europe, really substantial, country to country, with Denmark being by far the best. And Denmark has child-friendly policies for children. So things that are good for children happen to be good for children with impairments. And part of the message is that as strongly as we want to advocate on behalf of the kids we're interested in our business, we should be recognizing that if it's good for all kids, it'll be good for them as well. It's a kid with a fitness problem. This is not my granddaughter. The fourth F word is fun. And fun is about participating in things that are important to you, and fun is about personal factors. What's fun for you and fun for me may be different. So we need to remember this. And I talked about the fact that parents often have difficulty telling us what their kids are good at. It's really important to find out what the kids do for fun, or what is fun for them, and figure out how to take advantage of that particular personal factor in inflecting and in infusing our therapy ideas. So fun may be an individual thing, like listening to music. It doesn't matter what it is. The notion of participation in the International Classification Functioning Framework is involvement in meaningful life situations. And we like to say, drawing on a Ziggy cartoon from many years ago, when Ziggy climbs the mountain, gets to the guru, and says to the guru, "Guru, what is the secret of life?" And the guru says, "Life is doing stuff." And it's a really pithy reminder that if, once you're dressed up, have you got a place to go? Once you have beautiful function, what are you going to do with it? And I've made this point, or tried to make this point earlier. And we know from a lot of evidence that people with disabilities often have much lower rates of participation. So the question is, can we do something about it? And the answer is, of course, yes. First of all, find out what kids want to do and adapt those activities. Don't worry that kids are doing things nicely and normally. And by doing this, we are likely to be building kids' confidence, their sense of capacity, their sense of themselves, their achievement, and how other people view them. Really, really important. Fundamentally basic and simple, but we have been so seduced by the impairments and the need to fix the impairments that I think we've often forgotten this. And there are lots of popular examples, the Paralympics being one example of people adapting and doing things that many of the people in this room, certainly this person, couldn't possibly do. And quite remarkable. And it's quite remarkable until we realize that that's what they want to do and that's what they're good at. And then we stop being quite so amazed and simply are awestruck by the fact that people can, run on blades or, wheelchairs at phenomenal rates. And I don't know if any of you have ever seen the movie Untouchables. It's in fact it's intouchable. It's a French word. And if you haven't seen it, get it and look at it. It's a true story about a man with a significant spinal injury, based on a true story, a significant spinal injury, who he acquired while paragliding. And you see all the stuff he does with his amazing helper. It's a fantastic movie, and there are many, many examples. Rust and Bone is another recent example of a film that shows people with impairments doing great things. So think about fun and think about participation. Figure out what kids want to do, find out from them, find out from their parents, and then adapt it. Just as we adapt two-wheel bicycles with training wheels. Now, there's a concern about the adaptations, and are we going to make kids dependent on them? Well, how many people in this room have a kid who used training wheels? And how many of those kids are still needing training wheels once they learn to ride their bike? We forget that kids develop, they change, they acquire abilities they didn't have previously. And so they may not necessarily need a lifetime prescription of training wheels or the equivalent in other technical aids. If anybody knows how she can do this, please see me after. Okay, the fifth F word is friends. Social development, hugely important. Hugely important for all kids. And we got to figure out how we can help kids to acquire meaningful relationships. The quality is important, the quantity isn't. So question is, what can we do to help parents to encourage, empower, and enhance children's opportunities to develop and nurture meaningful peer connections? Those peer connections may be with able-bodied kids, they may be with other kids who are like them. And you know, there's always a discussion, should kids be in integrated or segregated schools? Well, that's a kind of dumb question when asked that way. If you're incredibly musical and your city has an arts program, you probably want your kid to be in that arts program if it's really important to them, or the visual arts program, or the sports program. Those are segregated to some extent. And if that's the right thing for that child, then it shouldn't be a philosophical bun fight. It should be, you know, what's appropriate. So there are times when kids with impairments want to be with other kids like them, and there are times when they want to be, and situations in which they want to be with the regular rest of the community. I think we need to be much more flexible in how we think about this, but always keep this in mind as something that is important to children's development. And there's the D word again. And of course the friendships may be with other animate creatures than humans. So the fifth takeaway message is think about friends. I always ask kids about their friends. I ask about who's come to their birthday party, whether they've been to a birthday party. I think we need to help parents recognize opportunities to structure things that will allow kids to have social connections. And again, recognize the trade-off between an hour of therapy and an hour doing something else that may be equally or perhaps more important to that child and that parent. And this is not to slam therapy. This is simply to say that I think we need to think about therapy in a context of F words that is bigger than the original F word of fixing. The final F word doesn't fit into the ICF framework, because the ICF framework, and I should have said this at the beginning, and I know you know this, is a cross-cut through a current state of things. This is where we are right now. This is what the condition is. These are the impairments, the activities, and so on. But if we think in the 4 dimensions of space and time and add time into this, then we have to recognize that kids are in a process of becoming. Most of us in this room hopefully will leave here by the end of the Congress with a few new ideas. We will be a little bit changed, but we won't be fundamentally different a year from now. But my granddaughter will be fundamentally different when she's 3 than she is at 2. And that is the nature of child development. And so we need to be thinking all the time about having one eye on the future and asking, how is what we're doing now, how is what we're expecting parents to do now potentially relevant to that child's process of being, becoming, and belonging. And this, of course, many of us have wakened up to the fact that our former children are now adults with cerebral palsy or spina bifida or muscular dystrophy or autism or intellectual impairment. And it's taken us a hell of a long time to recognize, among other things, that there are probably 3 times as many adults with cerebral palsy as there are children, because there are 3 times as many adults as there are children in our community. And people with cerebral palsy didn't get better when they turned 18, and they didn't die when they turned 18. They became adults. They became orphans in the system. And there's a lot of interest now, nationally and internationally, in what's called transition to adulthood, and the adult lives of people with so-called children's conditions. So with that perspective, we now have to be thinking not only about today and this week and this month and this particular activity, but thinking downstream as well. because the things we do now may and hopefully will have positive benefits later on. So the horizon needs to be part of how we're thinking about things. Think about the implications of the things we're recommending now for the future of this child. Help parents, as I said, to think about being, belonging, and becoming, and not just about today. Most kids who are developing typically don't ask permission. They just do stuff. We call it mischief. Mischief is an adult word. Getting into trouble is something that kids do, not because they're bad kids, but because it's the nature of kids to be busy and active and explore. We need to make sure that that happens to the best extent possible in kids with impairments. So this is how the F words fit into the ICF framework, and I've alluded to each of these and alluded briefly to a bit of evidence that supports each of these ideas. I want you just to think, in my second to last slide, to think about the fact that how in a modern way of thinking we might engage kids in an activity that's important to them, and that participation in activities might lead to changes in their capacity, which might have changes in their activity, which might have changes in body structure and function. In other words, this might be a subterfuge way to get at the things we think are important, like fitness. But having people go on a treadmill, as most of you know better than I do, is dead boring. Getting kids in activities that are important to them might in fact lead to improved fitness for social reasons or for whatever reasons they are. And this is, I say this backwards direction because to go back to where I started, the original notion was we had to start on the left side and move to the right. But the whole notion of the ICF framework is that you can start anywhere. And there are potential benefits in other parts of the system, not necessarily downstream, perhaps upstream. And so this is how we think the ICF thinking is making a difference to us. And the F words really is a package of ideas that hopefully makes some sense. What I love most about this picture is the kid's pissed off. Like his dad made him pee. So let's open the floor for some discussion, questions, comments. My uncle used to say to my grandmother, who felt insecure about her lack of education, she would ask, and she'd say, I want to ask a stupid question. And my uncle always said, there was no such thing as a stupid question, only a stupid answer. So all the pressure's on me. Please. I want to encourage the yes, but what about question. Okay, a brave person.
I have a yes, but what about question. My name's Jen. I'm from Edmonton, Alberta, and I've worked in PEDS for 5 years. I agree that parents are definitely the experts about their kid. What do you do when you say that to a family and they say, but I want you, like, what do you respond to that? Because I think it's hard to empower them when they feel like they want to get something out of the therapy session or visit with their pediatrician.
Thank you. Great question. I'll repeat it briefly. What do you do when the parent says, you're the expert, I want you to tell me what to do? Well, my first, that's a very common question about family-centered service. And I think the caricature of family-centered service is we sit there with our arms folded and say, well, what do you want to do? And then sit there in silence until they can answer. And that's silly. And that's not what you said. But it's a silly idea. The idea of being family-centered is to give parents the option to say, among other things, I don't know, give me your best advice. But that's different from us seeing the child in the waiting room, having them come in and say, I know what you need. Okay, I remember seeing a child referred to us at the age of 6 with Duchenne muscular dystrophy. He was known to have Duchenne muscular dystrophy. He was being seen at another clinic that came in to see us, and I said, why are you here? And they said, he's having trouble learning in grade 1. Nobody had ever asked them. They would go every 6 months to the muscular dystrophy clinic, and they would look at how he walked. They would check his back for scoliosis, and they'd say, he's fine, come back in 6 months. Nobody ever asked them, how's he doing, and what are you concerned about? So when parents give us permission to talk with them about the things that people like them might be interested in, we open up the menu, if you like, to what we're serving at this particular clinic, which is anything from this to this. We're not but we're not automatically telling them what to do. Next. Oh, come on. It's courteous to ask the speaker questions.
All right. Hi, Peter. It's Gail from Holland Bloorview.
Hi.
Excellent talk. Thank you very much. And I've been in this field for 30 years, and I'm certainly online with all your ideas. However, the yes but.
Good.
I think the talk should go two other places. One, I agree. I think a lot of families come in and their goals are, and I work with kids with CP, but also with kids after acquired brain injury. So you talked about strokes, you talked about MVAs. I work with the families that 5 years later come in for a consult and say, but they still don't have a heel strike. And I work with adolescents that come back from the stroke clinics at other hospitals and get referred back by physicians, neurologists, who say, but they still don't have a heel strike, and they should maybe be wearing an AFO. And why aren't they getting therapy anymore, when in fact the child really hasn't been getting active therapy for 3 or 4 years because they're participating in soccer, and they've got friends, and they're doing activities, and they don't want to see a therapist, and they've never worn an AFO, and they don't want one.
Yeah.
So I think your talk needs to go there as well, because it really makes our job tougher when families come back and say, yeah, but the doctor thinks the kid needs therapy.
Yeah. Thanks, Gail. I'm an equal opportunity preacher. I'll give this talk to anybody who wants to listen. I didn't invite myself here because I think you people needed to hear this. I was in fact invited. And maybe the subterfuge is that you guys will take some of these ideas, which you obviously, and I know Gail very well, would obviously make sense to you. I think we need to, as Gail says, we need to make these ideas much more broadly understood, particularly to my colleagues in pediatrics and in neurology. What's so interesting is recently we had a parent group, and we work, as you know, we work with Darcy Failings, and there's an Ontario Brain Institute project which originally involved kids with Hemi syndrome and now has been expanded. And we had a group of parents with us at McMaster and a group of parents in Toronto and some parents on the line. We were having a parent group. And one of the mother of an 8 or 9 year old who has a fairly dense right hemi, I don't know him, but I'm what she's described, and she's very upset because in the community she lives in, she can't get therapy. He doesn't fit in the children's treatment center anymore. The school doesn't have therapy. She's paying an awful lot of money for private therapy. And I said, well, what can he do? And she was stumped. She didn't know what I meant. And the other mother said, well, tell us about him. You know, what can he do? And it turns out he can do everything he wants to do. He's in an age-appropriate grade. He's doing some sports. He dresses. He feeds. He's independent on the toilet and so on. So I said, why do you need therapy? I said, you know, you can give him all the therapy in the world. He's still going to have a limited function of his right upper extremity. Now, Botox might help to release some of the spasticity, so he'll look less hemi-ish, but we can't fix it. And then one of the other parents said, you know, we go to the clinic, and the OT wants to know what he can't do and focuses on his impaired upper limb, and the physio focuses on his impaired lower limb. And everybody's focusing on what they can't do. And so part of the problem is our own approach to things in the first place. I don't know how important a heel strike is in the great scheme of life. But as long as people are obsessing about heel strike and kids having trouble with it, we're going to have the kind of examples you're giving. So part of the message, clearly, as you rightly say, is we have to change the way in which people are thinking about these issues, particularly in the context of child development. Don't forget that well-intentioned pediatricians and neurologists and community therapists were all brought up with older ideas. And unless they're thinking about these ideas the way I'm suggesting we could think about them, they're going to be bringing last year's message. Other comments, questions? Yeah. Use your outdoor voice. Oh.
I think with child development in pediatrics, you're dealing also with future development.
Yes.
So I guess in your context, I mean, I think as a society, we look very much to the future in terms of technology developments, and oftentimes we're dealing with the realities of what our current technologies and skill sets enable us to do. But I think with child development, probably a lot of parents are looking at what potentially could come down the road. So I just wanted your thoughts on that.
Well, there's no question that technology is empowering us in all sorts of ways, literally and figuratively, and we need to continue to explore and understand the benefits of virtual reality interventions, communication technologies, some of which are quite remarkable, but at the same time not put all our expectation into waiting for the next technology development. You know, if we want kids to exploit a technology, we want them to have an interest in doing whatever the technology will allow them to do. So I think we have to have a balance between hoping for new technologies which will enhance function and taking advantage of what we have now, and also reminding parents that when kids have an interest, people will take an interest in them. So building toward the potential to exploit whatever the technology is because they have something they want to do with it. Yeah. The drip is going to stop. That's me.
Just one more? Just one more?
Oh.
We actually...
Okay, she got there before you did.
Okay. Quick.
Hello. I'm a physiotherapist in long-term care, and I thought this was quite refreshing. I was wondering if you would go back to the ICE, the second to last
Can we go back,
slide.
gentlemen?
I kind of liked the end of it, the fun friendship.
À la fin, s'il vous plaît.
Oui, merci.
We. You mean this one or the one before?
Before. This one, that?
Oh, that one.
No, the other one. Thank you.
Okay. That's the F words package. And we wish that the philosophy was spelled with an F, because that would be another word for us.
Well, thank you very much for a wonderful, captivating talk that had a wealth of information and thought-provoking ideas that are very relevant to all areas of physiotherapy practice. And I think I certainly sat there and reflected back on my practice, and I think that there's a lot of wonderful take-home messages for all of us here today. So, Dr. Rosenbaum, on behalf of the Canadian Physiotherapy Association and all Congress delegates, thank you so much for being with us this morning to share this wonderful talk.
Thank you for being well behaved and asking some questions.
This concludes the Congress 2013 plenary session for today. Please don't delay in moving on to your first educational session this morning, as they'll begin promptly at 9:05 a.m. Thank you and have a wonderful day.